Hello everyone, myself Dr. Aditi H Jesing, under the guidance of Dr. Ina Desai from Vijay Medical College and Civil Hospital, Ahmedabad, am presenting a paper which is a literature review on anatomy of silence, mapping vestibulocochlear malformations with HRCT. Introduction. Inner ear malformations are found in 15 to 20% of patients with severe SNHL. A broad spectrum of inner ear malformation have been described and linked to developmental inserts at different stages of embryogenesis, and various systems have been proposed for classifying them. Radiological imaging is essential in assessing congenital SNHL, especially in patients being considered for cochlear implants, as it provides critical insights into the anatomy of inner ear, brain, as well as any coexistent middle or external ear anomalies. Anatomy of inner ear, we can see in the schematic diagram. This is the cochlea, this is the vestibule, semicircular canals. Cochlea is further divided into scala vestibuli and scala tympani, meeting at the helicotrema. This is the HRCT image of the same. We can see at the vestibule, cochlea, and the semicircular canals. Methods. A literature search was conducted using PubMed databases for articles published between 2005 and 2025. Keywords included vestibulocochlear malformations, inner ear anomalies, HRCT, and sensory neural hearing loss. Relevant studies focused on the radiologic classification and HRCT features of inner ear malformation in pediatric and adult populations. Articles not available in English or lacking radiologic correlation were excluded from this study. Result. This is the scenario classification. First is complete labyrinthine aplasia, also known as Michael's deformity, rudimentary otocyst, cochlear aplasia, common cavity, cochlear hypoplasia, incomplete partition of cochlea, enlarged vestibular aqueduct, and cochlear aperture abnormalities. Starting with complete labyrinthine aplasia, also known as Michael's deformity, where entire cochlea, vestibule, semicircular canals, cochlear and vestibular aqueducts are absent. So the petrous bone may be completely aplastic or hypoplastic, as in this case. An otic capsule may be rudimentary or may be absent. IAC is also defective, or there can be no IAC at all. Cochlear aplasia, we can see cochlea is completely absent, vestibule is dilated, and there is anterior displacement of the labyrinthine facial nerve. Common cavity, we can see here, this is the cochlea, this is the vestibule, connected by a cystic confluence, and there is no internal architecture of the cochlea. Cochlear hypoplasia, type 1. Now in type 1, this patient presented to our hospital. We can see bud-like cochlea on both sides. There is no internal architecture, no external architecture, modulus is absent. And this is the coronal image of the same. We can see a double IAC were present in this patient. Cochlear hypoplasia type 2, also known as cystic cochlear hypoplasia. Facial cochlea has a smaller dimension. Modulus is defective, interscalar septa are also not seen. Only the external outline is normal. Type 3, less than 2 turn. This patient also presented to our hospital with SNHL. He had 1.5 upturns present. Cochlear hypoplasia type 4. Here, patient has a normal basal turn, but the middle and the apical turn are severely hypoplastic. Incomplete partition of cochlea. Type 1. Here, cochlea is of the normal size. There is empty cystic cochlea, no internal architecture. Vestibule is also dilated and dysplastic. Type 2, commonly known as Modley's deformity. Here, basal turn is normal. Middle and apical turns have been fused to form a cystic cavity. Vestibule is dilated. Vestibular aqueduct is also dilated. This is the Mondini's triad. Incomplete partition of cochlea 3. Cochlea has interscalar septa, but the modulus is absent. Vestibular and semicircular canal abnormality. There is a dilated vestibule with stunted lateral semicircular canal. Posterior semicircular canal is normal. IAC is stenotic, and we can see effusion in the middle ear cavity and the mastoid. Vestibulocochlear nerve anomalies may also be present with the above mentioned anomalies. For that, MRI is the preferred modality. We can see here this is the normal sagittal section, and here we can see the cochlear nerve is entirely absent. This is a simple flow chart summarizing this. If a patient comes with SNHL on HRCT, if we see labyrinthine structure is completely absent, it is called Michael's anomaly. If there is normal or malformed vestibule and superior semicircular canal, but absent cochlea and cochlear promontory, it is cochlear aplasia. If there is only one cyst without separation, it is common cavity. If separation is present between cochlea and vestibule, we look at the size of the cochlea. Smaller size cochlea is cochlear hyperplasia, and if it is normal, it is incomplete partition defect. Discussion. HRCT enables precise assessment of the osseous labyrinth. However, its interpretation is challenging due to overlapping features between normal variants and true anomalies. Accurate diagnosis requires careful assessment in multiple planes, standardized classification, and often MRI correlation to avoid pitfalls, such as misinterpreting nerve aplasia, overdiagnosing vestibular aqueduct enlargement, and therefore a dual modality approach should be followed. Congenital inner ear malformation have been classified by Ramos et al. Into three groups with respect to their implications for feasibility of cochlear implantation surgery. First group is gross malformations constituting surgical contraindications like labyrinthine or cochlear aplasia. Second group is major malformations like common cavity contributing to increased risk for complications like CSF leakage, meningitis, and potential electrode displacement. Third group is minor malformations like partition defects, aqueductal abnormalities, and vestibule abnormalities. Next cases. So newer modalities have been emerged like 3D reconstruction and AI-driven image analysis, which helps in automating classification and predicting surgical outcomes. Conclusion. Vestibulocochlear malformation represent a diverse group of anomalies with significant implication for hearing restoration strategies. HRCT serves as a cornerstone in their evaluation, offering detailed insight into bony anatomy crucial for surgical planning. A thorough understanding of this malformation not only aids in accurate diagnosis, but also optimizes patient outcomes, particularly in the context of cochlear implantation. These were my references. Thank you.